One of the things we added actually last year to this course is this next hour or so, maybe a little less, of innovations within our field. And so each of us have sort of handpicked a component of our field that we think has changed quite rapidly, or there's new developments, or there's a new treatment option that we can use. So I'm going to talk about some innovations in thyroid eye disease, and then I'll pass it to Lila, and then I'll pass it to Kyle. And then we'll finish the afternoon a few presentation pearls, and then Lila and Kyle will each present a case to you, just so you can see how their style is in presenting a case as you practice all of your cases, which we're excited to start hearing tomorrow. I am a consultant for one of the companies that makes a drug I'm going to talk about, Horizon Therapeutics, and that's a drug that is utilized for TED or thyroid eye disease. So, what's that? Teprotumumab, exactly. Yeah, I'll use that word actually for the drug Tepro. We can just say Tepro is easier. So this is Bart Free. Bart Free was one of my first mentors in oculoplastic surgery at Kellogg Eye Center. Where's my Kellogg connection? I'm trying to find her out there. Oh, there you are. It looks very fast. Sorry. Kellogg Eye Center, yep. So he was actually there when I was a resident 20 years ago, and he was my first mentor in oculoplastics. He loved taking care of thyroid eye disease patients. They can be a challenging subset to take care of, but he gave this talk and he basically provided his mentality for taking care of these patients. Make the diagnosis, provide emotional support, prevent vision loss, and then maximize their function and appearance once the disease stabilizes. And it's really amazing that 25 years later, I think those same goals hold true, although there may be a slight change in how we manage the patients, given new drugs entering the arena. One summary slide on thyroid eye disease. The first time you see these patients, it's helpful to classify them as mild, moderate, or severe. Remember, the severe patients are the ones that might have extra risk factors for severe disease. Older age, male patients, smokers. And the one that I like to really harp on is acuity of onset of the disease. Those patients that show up in your office and it's been like 4 or 5 weeks and they've had a massive progression or change, they might be heading in the wrong direction too quickly. So pay attention to how long it took. The ones that show up and they say, you know, somebody started noticing in pictures my eyelids looked a little different or my eyes looked different over a year, not as worried as somebody who comes in very quickly. And then from an ophthalmic perspective, just figure out what actually matters to us. So there's really 4 main things. It's exposure keratopathy from eyelid retraction and proptosis, strabismus, which we know happens in almost up to half of the patients with this disease, or double vision, and then in about 5% or so of patients, compressive optic neuropathy. So those are the main ophthalmic sequelae, but it's not fair to assume that's it, because these patients most commonly are young women, like 40s women, who have had a massive change in their appearance. So there's a lot of psychosocial impact that happens to the patients, whether that be avoiding pictures or putting on sunglasses or trying not to turn their camera on a Zoom meeting, that type of stuff. So you want to ask the patients about that. One thing that's fascinating to me about this disease is how heterogeneous the presentation is. All of these patients have TED, but they all look quite different and have different presentations. There's an underlying theme, though, with the disease that we're starting to learn more and more about, and that's the insulin-like growth factor 1 receptor upregulation in the disease. And that actually is most likely something that you saw on the test this morning, that the IGF-1R, or the insulin-like growth factor receptor, is upregulated in the fibroblasts of Graves' patients. And that's where there's now some targets being one developed and many in development that I'm going to talk about to attack that and block that insulin-like growth factor 1 receptor at the level of the orbital fibroblast, preventing the inflammatory cascade that happens in the disease. And interestingly, many of us think about the disease as an inflammatory component and a non-inflammatory component. You may have been taught this. And that's true. Some of the patients present with a high clinical activity score and they really look inflamed, and others present quietly and they don't look inflamed. But when you look at the orbital fat in these patients, that IGF-1R receptor is upregulated. There's more of it present regardless of inflammatory status. And I think that's important as we'll talk about when we start to try to think about treating these patients with a targeted monoclonal antibody to block the inflammation. We're now starting to look at whether we can also treat patients who don't have inflammatory signs and symptoms. And it questions our classic 1950s thinking of Rundle's curve, because we think of it as this inflammatory cascade and then a stable component of the disease. But just remember that IGF-1R is upregulated regardless of where you catch that patient in their disease. So we have lots of different treatments, and I'm going to talk about non-surgical management today because that's where the bigger changes have happened in this disease basically since 2020. Or earlier, actually, when you look at these two studies, these are phase 2 and phase 3 trials published in the New England Journal of Medicine in 2017 and then 2020. That led to the FDA approval of teprotumumab, Tepro, or the trade name Tepezza, for thyroid eye disease. And I wanted to show these trials to you. But before I do, who has heard of teprotumumab prior to this talk? So like a little less than half of you. And that's not unheard of because it's not available in any of your countries yet. But it definitely will be. And some of your countries sooner than others. They're moving the drug to Asia, to Japan, and to Latin America, and then Europe. So those are sort of it's going to happen. Eventually it's going to be available everywhere. And so it's helpful to know this. The primary thing they looked at in these studies was reduction in proptosis of at least 2 millimeters in the worst eye. They also looked at double vision, quality of life, and improvement in inflammation, the clinical activity score. For these two studies, the patients had to have thyroid eye disease for less than 9 months. So these are brand new diagnoses of TED. Okay, so it's a subset of the disease. It's those patients who just noticed the eye changes and got treated. And if you look, this is the phase 3 study, but these are the patients who got teprotumumab, and these are the patients who got placebo. It's an infusion. It's a monoclonal antibody, IV infusion, every 3 weeks for a total of 8 infusions. So it's a 24-week treatment. And 83% at that final endpoint of 24 weeks had that reduction in proptosis of 2 millimeters or more. The other part of this slide that I always point out is the fact that after just 2 infusions, over half of the patients already noted they'd already hit the endpoint. So in many of these patients, and in my experience, especially the inflamed patients, it works pretty fast. I usually tell them by about 3 infusions, you're probably going to notice an improvement. And then if you look at how much improvement do they ultimately get, on average, they get about 3 millimeter reduction in proptosis when they finish the full treatment course, 8 infusions. If you look at placebo versus the Tepro, this slide's really interesting. The 0 is their baseline Hertel exophthalmometer reading. -2 means that they met that endpoint. They improved by 2 millimeters or more. And if you look here, the natural course of the disease at the end of treatment, this is what the disease does if we do nothing, which is what we used to do. We watched them, right, for a while, and then we did stuff later. So some of the patients get worse, some of the patients stay the same, some of the patients get a little better, very few get a lot better. That's natural course of TED in the acute phase. If you give them the Tepro, here's our baseline, and here's our endpoint. You know, we're looking for how many people can get to this -2, and we know it's 83%. I just told you that. But what's interesting is everybody improved. So even these people here who didn't make the -2, they still improved. And my guess, when I look at this, is that these people might have been these people. They would have probably gotten, maybe, I don't know, they could have possibly gotten worse if they didn't have that treatment. And then you've got some who had some pretty drastic changes, 4, 5, 6, even 7 millimeter reduction in proptosis. Again, this is the worst eye. They also looked at the not the worst eye, and those did better too. Double vision improves in 70% of patients who have double vision to start with, and it goes away completely in about half of the patients. Side effect profile is very important to think about. The most common thing people report with this is muscle spasms and fatigue. Those are tolerable. The ones we really think more heavily about, there's a chance for hearing impairment. It's at 10% risk. And so we've altered the way we take care of these patients to do baseline audiology prior to treatment. And if they notice anything, we repeat that audiology through our ear, nose, and throat doctors. Blood sugar can elevate, especially in diabetics or people who have prediabetes, and that's about a 10% risk. So we watch hemoglobin A1C. And the other thing to keep in mind is you cannot be pregnant or get pregnant within 6 months of the drug. It'll cause birth defects. And so we monitor pregnancy tests in women. We recommend contraception in men and women who are on the drug. And so I talked about the pregnancy. You can't treat kids with it. It is contraindicated below the age of 18. And it can worsen inflammatory bowel disease. So if you have a patient who has inflammatory bowel disease, just use caution, work with your GI doctors. There is some flare or rebound in some patients, and we don't exactly yet know how to predict which patients may get better, and then over a period of about 6 months as the drug washes out, get worse again. They tend not to get worse to the point where they were before, but they can rebound. And when they looked at rebound, that happened in about 30% of patients. They did define rebound very tightly. So if a patient had a worsening of proptosis of 2 millimeters in the eye that was their worst eye, they count as a rebound. So that could also mean, and oftentimes did mean, that it was a patient who improved by 5 millimeters, and then they worsened by 2. They're still better by 3 millimeters, but they count as a rebound in the way they're counting the stats. And the other way they counted it as a rebound was if the clinical activity score, the inflammatory marker, increased by 2 points. So if they developed recurrent inflammation. So they still, oftentimes in my experience, they're still better if they rebound, but they're not as good as they were before. And they looked at these patients and they determined whether they can be retreated, and they can. And so some patients do wind up with a second course of the infusions, depending on their discussion with the patient. This study here looked at the patients who got the placebo drug. So they get the placebo in the first arm. I showed you that scatter plot. And then they were offered the opportunity to have Tepro. So now we have patients who are 2 years out as opposed to 9 months out getting the drug. And the main point is, even 2 years out with the drug, they got better to the same level as the patients who got it that first earlier time period. So as the drug became available to us, it was 2020 when it was FDA approved. And it's approved, the label is very broad. It's for thyroid eye disease. So people started using it not just for patients within 9 months of the disease. And we learned that it can actually work in patients who have longer stages of the disease, and also, in my experience and in this study here, in patients who even have compressive optic neuropathy. It can reverse or improve compressive neuropathy, and it was contraindicated in the phase 2 and phase 3 studies. If a patient had compressive disease, they were not allowed to be in the studies. So the companies just finished their phase 4 trial of chronic patients. These patients either received placebo or Tepro, but they had to have the disease for more than 2 years and for less than 10 years. The average time in this study is 5 years. And they had to have a clinical activity score of 0 or 1. So they had to be basically that non-inflammatory type that you can imagine. They've released what they call top-line data, which means they're not providing us all the details yet. They've just provided a press release. The paper will come out soon. And they found that 62% of the patients in this subtype responded by way of decreased proptosis of 2 millimeters or more. The average amount was 2.5 millimeters. So a slightly lower response rate in this subset of patients, but still a response rate in more than half, and a slightly smaller amount of reduction in proptosis than those more inflamed patients. There was a meta-analysis done looking at methylprednisolone, which I'm sure probably all of you are comfortable putting thyroid eye disease patients on if you need to. And the main points of this are two. One is that the Tepro did better than methylprednisolone in terms of diplopia response, but prednisolone does help diplopia. It doesn't really help proptosis. And so as one would expect, the proptosis rate for Tepro was improvement in proptosis was significantly better than the methylprednisolone group. So we've got this like shifting landscape in TED, because whereas it used to be a watch and wait, do surgery for most patients approach, now we have these targeted therapies and other companies are looking at it. I mentioned the chronic study. They're also doing a study looking at different dosing regimens, 4, 8, or 16 infusions. No data yet on this study. And then there are a few other companies who now have entered the space. This is Viridian. They also have an IGF-1R blocking agent. They have two formulations. One is IV, one is subcutaneous injection. The first company, Horizon, also is working on injecting subcutaneously their drug. So we may change the mode of injection. It's expected that this company's drug will work very similarly to teprotumumab and will be FDA approved probably in 2024. And the question in my mind and many's is really whether the sub-Q version will work as well as an intravenous version. And then there's Immunovant, which has a drug that blocks the neonatal FC receptor, which is part of the IgG inflammatory pathway. They are in phase 2 now. This is also a self-administered subcutaneous injection, and we'll see what their trial shows. Different mechanisms, so time will tell how this drug might play in. And then the last one was quite interesting. Actually also came out of University of Michigan. This is a drug that was invented by an endocrinologist at University of Michigan. Is linacidibit. I can't even say it, whatever. But it's an oral IGF-1R receptor blocker. And they're in phase 3 trials right now. And so this one's also expected to be FDA approved by 2025. So a lot of new things happening in this disease, but I'll bring it back to Dr. Free and what I like to think of as the free pearls that he gave us. It's still the same goals. It's still, make that diagnosis, classify the patient the first visit, provide them with emotional support. The good news is it's a little bit easier now because we actually have some treatment options that are available in that early phase if we want to use them. Prevent vision loss, maximize comfort and appearance, but also utilizing targeted disease modification. And then what I'm finding is by doing that, the surgical rehabilitation later is becoming a little less complicated. Less bony decompression, more fat decompression, less strabismus surgery required. Still needing a fair amount of eyelid surgery after treatment if they have retraction. Those are some references.
So I'm just going to be talking about some innovations in the glaucoma space. So we have a few different innovations that are either happening now or in the pipeline. So just talk a little bit about what's new in medications and lasers and MIGS, and then some portable testing updates. So new in medications, first of all, actually, Kyle Godfrey reminded me that Rocklatan, which I alluded to in my talk earlier, is not necessarily new in the US, but I think it might be new in other parts of the world. So that is one of our medications that has been a game changer as far as intraocular pressure drop. It's widely available, but it may not be something that's in everybody's arsenal right now. But certainly Notarsadil, which is Repressa, and Notarsadil latanoprost, which is Rocklatan, are both very useful medications. The other ones that I really want to talk about, though, well, the most important one really is probably Durysta, which I also spoke about a little bit in my talk earlier. This was approved in March of 2020. Kind of took a little while to get off the ground, but it's definitely currently in use, certainly in the US. And it is a bimatoprost pellet that we inject into the anterior chamber. It releases over 4 months. Currently only in, it's only permissible to use it one time, but there are trials looking at multiple dosing. It releases over 4 months, but clinically, I think the effect lasts much longer than even 6 months. And I'm seeing patients 9 to 12 months after the injection that still have some on board. The drawback there is they've had this great response. The response wears off, but you can't offer it to them again right now. But it is useful to help get somebody off a prostaglandin drop for a bit. The other interesting medication that's still in phase 2 trial is the iDose from Glaukos, which is a travoprost-filled titanium implant that's surgically implanted into the angle. So this is not in the office, but surgically implanted. But it can be exchanged or refilled, which I find very interesting. And then the last one, which I haven't really found a lot of information about, but it is a intracameral erodible travoprost implant. I'm thinking it's somewhat similar to Durysta, but that's still also in trial. So the Durysta, which some of you may have already seen, is a teeny tiny little pellet, the size of, compared to our dime, very tiny. And we put it in an injector into the anterior segment. So the injector has like basically a needle that comes into through the cornea, and the pellet then sort of drops down very quickly into the angle, and really, has been very helpful in kind of long-term control. So that's been a really nice, useful thing to implant in the office. The only thing is that, of course, any injection, you always worry about inflammation and, of course, infection. So that's a little bit of it's a little bit time-consuming to do these in the office, I find, but they are very effective. So this is just a schematic of the iDose. So this is, again, surgically implanted into the angle, and it releases travoprost and can theoretically supposed to be either refilled or just exchanged. I'm curious to see what that's going to be like. So, and then some other medications that are in the works are looking at the subconjunctival space. So one of them is called the ID by BioLight, and it's going to be a latanoprost pellet. And studies were showing that it gave a very significant reduction over 12 weeks, probably longer. And then the other one is liposomal latanoprost, which will be an injection into the subconj space. And again, similar action to topical latanoprost. I'm not sure when these are, I haven't been able to find any information about when these are available. I feel like some of these have been in the works for a while, and then they kind of drop off and come back. So we'll see what happens in the future. So new in lasers, this is actually from Belkin. It's called a direct SLT. It is available in Europe, so some of you may have already seen it. I have not. But it is a lens-free SLT, which is very exciting. And you can directly treat the trabecular meshwork through the peripheral cornea. And ergonomically, it's much easier for a patient. They can sit or stand. And it's actually automated. So there's a consecutive pattern of treatment, which probably has its pluses and minuses, but I feel like it's more plus than minus. The thing is, when we do SLT now with our lens, I can pick and choose where I'm treating in the angle. I'm not sure if there's a pattern here or if there's a program that allows you to pick and choose where you're treating in the angle and skipping areas of synechiae or iris processes. But I think that the idea of a direct SLT, a direct laser without a lens, is really nice, because half the battle when we're doing lasers is actually getting the lens to stay in the eye without people blinking them out. And then just new in the minimally invasive glaucoma surgery, I spoke before about the iStent. So the iStent has gone through several iterations over the past years. First is the original iStent, which was just one stent. Then came the iStent Eject, which is 2 stents, and then recently approved for the iStent Infinite, which is 3 stents placed in the nasal angle 2 to 3 clock hours apart to, again, in combination with cataract surgery and to maximize outflow. So I think we're still waiting to get that approved at our center. So new in testing is tonometry, which is obviously always a big challenge. And one of the bigger challenges that we realized, especially that really was brought home during the pandemic, is how to monitor people when they're not able to get to the clinic. And so there's been a lot of investigations into portable testing and into home testing. So there's some portable and home options in tonometry. So one of them is the iCare, which is currently very much in use. We have an iCare in the clinic, and it is a rebound tonometer that does not require anesthesia. It is moderately reliable, and it's best for people with kind of really honestly like more or less average pressures, but it is very helpful. And there are two different types. Actually, I'm just going to go forward for a minute. So there are two different types. One of them is one that we more or less use in the clinic. And they're just different like just sort of set up a little bit differently, but there's one for use at home. They're a little bit pricey, but for somebody who you're not, they seem to be getting worse even at low pressures. These can be useful to send a patient home with for a few days and have them serially check their pressure, and sometimes you can be surprised where their pressure is spiking to. The second innovation that we have is the triggerfish, which is actually a contact lens that measures intraocular pressure flux through the changes in the cornea circumference. It does provide for continuous intraocular pressure monitoring through data that's sent through a cable, and then there's a recorder that relays the data transfer to a doctor. And then the iMate, which is available in Europe, so I'm not know if anybody's ever seen this, but it is actually a sensor surgically implanted in the suprachoroidal space. And then a patient has a special reader that they hold in front of their eye to check the intraocular pressure, and that does correlate very well with Goldmann tonometry. So this is the triggerfish, and again, it measures intraocular pressure basically by changes in the corneal circumference, and then has a data transfer to the doctor who's taking those measurements. I have actually not seen this in action. I don't know if anybody here has. I think it's probably a little bit of a hard sell for a patient, but I guess if you could send them home with it on to sequentially measure their intraocular pressures for even a few days, I think would be very helpful. Very interesting and a little scary to me, but is actually in use, is the iMate by Implant Data, which again is a surgically implanted suprachoroidal sensor, and then does correlate very well with Goldmann tonometry using this special reader on the right there. And then lastly, there's some new innovations in testing in visual fields. We're always looking for a better way to test peripheral vision, a faster way, a less anxiety-provoking way to test peripheral fields. And so there are three main ones that there's a tablet-based by Zeiss, and they're faster than Humphreys, and they can be done at home. The con is that it's a less reliable test because they're being done at home, so who even knows what kind of conditions are happening around there. The Melbourne Rapid Field, which is actually an app, and it's a modified 24-2. So it's very similar to the Humphrey, and it gives good intertest variability, but it has low sensitivity for early defects. So it's probably similar to like what we call our CETA Fast, which does not really pick up very small defects well. And then the last one, which I thought was interesting, was the virtual reality headsets. There are several available types, and they offer better ergonomics, and they're less expensive than some of the machines, but you can get variable outcomes as opposed to the traditional Humphrey field analyzer indices. They're useful for kids, they're useful for people who are in wheelchairs, they're useful for anybody who cannot really position well at a visual field machine. And I think they're probably going to become more in use in the clinical setting because we obviously have, and they're very fast. So we do have a lot of people who find it very challenging to sit at a machine even for 3 minutes an eye. So this might be the wave of our immediate future.
So one of the things that I love about oculoplastics is that it's very hands-on and very surgical, but it's hard for drug companies and other companies to monetize that in some ways. So a lot of people like to make fun of us in oculoplastics, so there's not a lot of innovation. And when I was thinking about going into it as a resident, my chairman at the time said there hasn't been any innovation in oculoplastics in 50 years. It's, they're still doing things the same way. Gary probably highlighted one of the biggest, Dr. Lelly, one of the biggest changes in our field from a pharmacology or therapeutic standpoint with Horizon. Probably one of the biggest new surgeries really happening in oculoplastics in the last few years is corneal neurotization. Has anybody been involved in the care of a patient who's undergone corneal neurotization or had a nerve transfer? Do you remember the details of the patient, what condition they had or what they were being treated for?
Pretty much for patients with central surgery without paralysis.
Yeah, so it's really a great treatment for neurotrophic keratopathy. So neurotrophic keratopathy is really sort of anything that disrupts that feedback loop between sensation on the front of the cornea, reflexive tearing, and sort of production of those trophic growth factors that support the ocular surface health and sort of help the cornea maintain its epithelial barrier. So when you get any sort of breakdown in those things, you lead to sort of epithelial loss and defects, persistent non-healing corneas, and then eventually sort of activation of the stromal fibroblasts and scarring within the central cornea. There's a lot of pathways that can lead to this, diabetes and essentially, loss of sensation from diabetic disease, certainly actual diseases affecting the nerve itself, trauma, laceration of the nerves, orbital surgery, lesions like we talked about this morning in the back of the orbit where these, the nerves originate, the first branch of the fifth cranial nerve, or certainly infectious processes. But all of these come together. They can cause, again, impairment sort of that reflex pathway that's producing tears and producing those trophic growth factors. And then you basically, again, just get sort of these persistent epithelial defects, breakdown, and activation of the fibroblasts that cause scarring. So there is sort of one new pharmacologic treatment. Oxervate is sort of a recombinant human neurotrophic growth factor that it can pharmacologically improve this, but as Gary sort of alluded to with Tepezza, it's very, very expensive. I think an 8-week course of treatment is around $100,000 for this drop, which may not put it in the hands of many patients. Another option is corneal neurotization, which is essentially borrowing the nerve either from the ipsilateral side or the contralateral side, one of the branches of either the first cranial nerve or the second cranial nerve, the second division of the fifth cranial nerve, to sort of reinnervate, provide sensation to the cornea, and restore those pathways that provide the tears and provide the growth factors to the cornea. This is, has the cost of surgery, the surgeon's time, the anesthesia fee, the OR fee, but doesn't actually have any pharmacologic cost associated with it. So it may actually be a great option for a lot of places that either don't have access to Oxervate or for patients who can't afford that treatment. So the basic, ideas are, again, sort of if you have an insensate cornea, let's say on this side, you can borrow the supratrochlear or supraorbital nerve and either directly rotate it down. You sort of rotate, and we'll show a video in just a second of this exact surgery here. Taking that nerve, rotating it down, tunneling it subconjunctivally, and implanting it sort of on the side of the cornea, either at 2 positions or 4 positions to, again, sort of restore that pathway. Just through classic sort of Wallerian degeneration, when the nerve undergoes some injury, it stimulates new growth, and you get all this axonal sprouting, and it actually eventually will reinnervate the cornea. You can do that on the contralateral side. Let's say on this side you had a trauma, someone underwent a laceration or had a really bad herpetic infection that actually killed the nerve. On this side, let's say you can borrow that ipsilateral or contralateral supratrochlear or supraorbital nerve, rotate it around and provide the same thing. The other option is to use what's called an interpositional graft. This can either be the patient's own nerve, so something like the sural nerve in the leg, or you can use an allograft or a donor graft, essentially cadaveric nerve material to connect these. And it can be either the same sort of process where you take the, sort of the infraorbital nerve V2 and branch it and sort of use that interpositional graft to then, pass up and innervate the cornea on the same side, or the contralateral side using potentially the supraorbital or supratrochlear nerve. These grafts can either be what's called end-to-end, where you're actually, sort of cutting it and interposing it directly to the end of the nerve, or end-to-side, where the nerve is kind of what's shown here, where the nerve is wanting this way. You induce a small injury on the side, open up the nerve sheath, and coapt it directly to the side. So that's end-to-side branching. So we're going to show a video here. This is basically, let me just go back one second. I'm going to show basically this technique. So we're basically taking an ipsilateral supraorbital nerve, rotating it down to provide sensation to the cornea. This video was provided by one of my friends, Ilya. I've done these surgeries in the lab, but I actually have not found a good patient who's a candidate for it yet. So this was shared by my friend Ilya Leingold, who was one of the people who really pioneered this when he was at Duke. He's now in Idaho in the United States doing the surgery, but I think he's one of the best surgeons that I've seen do this. I've done his cadaver labs and worked with him on this, and he was kind enough to share a video with me here today. So he's showing an ipsilateral. So we're going to start just by making a skin incision, just like we would in any orbital surgery, dividing the orbicularis, and eventually we're going to kind of bluntly dissect up to the superior orbital rim. He's going to incise along the arcus marginalis, and then sort of bluntly dissect over to actually expose the neurovascular bundle, the supraorbital or lateral, neurovascular bundle. Here it's a lot of blunt dissection, and I've done this with him in the lab. And the nerves are tough; they can take more, sort of strain than you think they might be, but you really don't want to use much sharp dissection. So a lot here he's going to be using Q-tips and scissors to sort of expose and bluntly dissect this up. You want to get about 4 centimeters. So once you have about 4 centimeters, that's enough to rotate down. And so here, this is obviously sped up a little bit, but the goal is to, again, get that nice specimen here, cuts it distally, and now he's sort of cleaning up all of the, sort of the muscle, the frontalis muscle, some of the fibrous tissue that's surrounding it, to really get just clear, exposed nerve. At this point, just to minimize manipulation, he's going to pass a traction suture through the tip of it to have control of it and allow us to tunnel it without too much, direct damage or injury to the nerve. This is just a blepharotomy going up and making a full thickness hole in the eyelid, then tunneling that nerve back down. This is, again, the supraorbital nerve. Here, a little conjunctival incision, sort of about 8 millimeters supranasal, and then another one similarly, right on the limbus. And basically just tunneling it down right to the limbus. And then here he's going to kind of freshen up the edges. And again, you can do 2, you can do 4 branches here, but the goal is to put them right up to the limbus. So when you get that Wallerian kind of degeneration and the axonal sprouting, it can interface with the actual nerves within the cornea, the longitudinal, sort of ciliary nerves, and provide sensation. Here he's putting a temporary tarsorrhaphy. He'll put a pressure patch, and he just glues these in place. He doesn't actually secure them with suture, so they're just kind of held in place. The pressure patch stays on for several days, just to give the glue kind of time to set this in place so it doesn't move around or migrate away. And that's pretty much the whole surgery. It's actually not that complicated of a surgery. For me, my biggest thing has been finding good patients in our population. And I'm always knocking on Kim Sipple, who sits in our office next to me. She's one of our cornea specialists. I'm always asking her to send me patients. And I hope the goal, sometime in the next few months, I can find a good patient here. What do we know so far about corneal neurotization? It's really been going on for kind of in earnest for about 5 years now. It definitely works. Corneal sensation improves and visual acuity improve. We do know that in looking at the studies retrospectively. The final visual outcome we know probably depends on the initial acuity, and I think that has to do with stromal scarring. So even if you improve corneal sensation, the epithelial defects heal, it's not going to improve that deep sort of stromal scarring. So those patients may still need corneal transplants. And in the first major literature, I think this is a good paper to review if you haven't seen one. We discussed this with our residents at a journal club last year. About 7 patients in that series underwent corneal transplantation successfully after corneal neurotization procedures. So once you restore sensation, once you restore sort of that feedback loop, then you can go on to transplant these patients at some point. One thing that was highlighted in this review of looking at kind of, Ilya Langgold is the one who just showed us that video, and Andrea Kostler's at Stanford. I think they've done a big bulk of these procedures in the first few years. They found that in their series, 18-year-old patients and younger do better. Probably they just have more robust growth factors. They're healthier. They're just better healers overall. That doesn't mean that older patients necessarily do worse, but the patients who've been sent to me, my cornea colleagues are in their 70s and 80s, and I haven't, I wanted to do my first one in that sort of demographic. I think younger patients certainly undergoing, bad traumatic episodes, herpetic infections or other things may be good candidates. Things that we don't still know, kind of alluding to that, we don't know who the best candidates are, how to select for these other than for very young patients. We don't know who the best people to undergo this treatment might be. We don't know really what the best treatment for neurotrophic keratopathy overall is. Is it that recombinant human growth factor drop? Is it surgery? Is it amniotic membrane? We don't really know. And in studies that have kind of looked and compared all these treatments, everyone's done about the same, which is good that we have lots of options, but we don't really have a definitive best treatment. But I will say again, for patients who don't have access to the recombinant growth factor, the surgical technique could be a good option for them. And then we also don't know what the role of the recombinant growth factor is before or after surgery. Is there an optimal regimen to dose them before undergoing the neurotization procedure? Is there an optimal regimen afterwards? We just don't know. And we also don't even really know what the best technique is. When they looked at, these people who've done about 50 of these aggregately between, 4 or 5 surgeons, nobody's done a lot of them. Everyone's done things slightly different. In general, they all do okay, but there isn't a best or defined, perfect surgical technique at this point. So I think it'll be interesting. This was just from about 30 minutes ago when I Googled, in PubMed searched, corneal neurotization. You can see really over the last 5 years, this has exploded. So I think this is a technique that's going to rapidly kind of move to the forefront for neurotrophic keratopathy. I think we're going to refine our surgical techniques and certainly understand how to better treat these patients. So I think probably more questions than answers regarding this technique at this point, but I think this is something that definitely will find its way to your guys' practices within the next few years.